Okay, so good evening, everyone. Welcome to our third training event of fall 2021. I'm Dr. Julie Tennille, Principal Investigator and Project Director for our HRSA funded program that we've branded Education and Programming for Integrated Care, known as EPIC. I'd like to express my gratitude to the team behind the scenes, which includes Dr. Cheryl Neal McFall, co-PI and program evaluator, Wendy Myers, our amazing grant program coordinator, our research assistant, Sarah Fisher, and our graduate assistant, Fatima Bakayoko. We are so incredibly excited about our two presenters tonight, and I'll introduce them momentarily. So due to the size of our audience, we'll be taking questions for our speakers at the end of their presentation. So please enter your questions in the chat box throughout their talks. Fatima Bakayoko and the rest of the team will be monitoring for themes to pose to our presenters toward the end of our time tonight, and Fatima will be closing out this evening's event. The goal of this research and training grant is to expand numbers of well-trained MSW, MED school counseling, and PsyD professionals working with children, adolescents, and transitional aged youth in high need and high demand areas capable of delivering evidence-based behavioral health services in our region and beyond. All right, so let me tell you about these incredible presenters that we have tonight as you're finishing your pretests. So Dr. Ebony White is a licensed professional counselor, a national certified counselor, and an approved clinical supervisor. She is an assistant clinical professor in the Department of Counseling and Family Therapy and the program director of the Master in Addictions Counseling Program at Drexel University. As the executive director of the Center for Mastering and Refining Children's Unique Skills, a nonprofit organization, she focuses on expanding developmental pathways for at-promise adolescents in Trenton, New Jersey, through mental health and social support. Dr. Ebony's research interests broadly focus on advocacy and social justice within the African American community. Specifically, she's interested in the impact of individual and systemic trauma on the development and functioning of individuals and families within the African diaspora nationally and globally. She's done trauma-focused mental health work in Haiti and in her hometown of Trenton, New Jersey. She's appeared on CBS to discuss the impact of mass shootings on mental health, as well as the everyday violence that plague under-resourced communities in urban settings and the subsequent trauma response that may occur. Her opinion is often sought out around topics of mental health, trauma, and racism, and has been featured in numerous outlets, including Newsweek, Medium, the Philadelphia Inquirer, Pop Sugar, and the New York Times, just to name a few. In 2007, Dr. Ebony received the Woman of the Year Award from the Mercer County Commission on Women. She also received the Community Service Award from the New Jersey State Federation of Colored Women's Clubs and the Carver Youth and Family Center in 2018. In 2021, she was awarded the Dr. Judy Lewis Counselor for Social Justice Award from the American Counseling Association. She's the president-elect of Counselors for Social Justice and the immediate past chair for the North Atlantic region of the American Counseling Association. And now to our second speaker for this evening. Dr. Kimberly Mcclellan is an assistant clinical professor in the College of Nursing and Health Professions at Drexel University. Kimberly's primary clinical focus is driving the evolution and application of care models formulated to advance cultural and gender-specific care, access, and outcomes. Her mission includes the development of culturally effective care systems and integrating such findings in the teachings and efforts of a new generation of nurses and care professionals. These efforts are further disseminated regionally and nationally by activities such as her membership of the Medical Committee of Access Matters, formerly the Family Planning Council, her status as founding vice president of the board of the African Family Health Organization, and her service as speaking faculty for the National AIDS Education Training Center. Dr. Mcclellan holds nurse practitioner board certification in both women's health and family practice. She has extensive experience in the clinical areas of women's health, family planning, community health, and HIV primary care. By invitation and accepted peer review, Dr. Mcclellan has had the opportunity to publish, lecture, and consult nationally on these subjects, including African cultural aspects of HIV, through service on the planning committee of the National African Health Initiative of the Office of Minority Health. Kimberly's research interests include African and gender-related cultural aspects of HIV primary care, and her qualitative research regarding the integration of translational concepts such as communities of practice, education, cultural humility, and health promotion continues to inform evidence-based care models. Dr. Mcclellan maintains her active membership in the American Nurses Association, as well as the Pennsylvania Coalition of Nurse Practitioners. She is additionally a member of the Nursing Honor Society of Sigma Theta Tau International. And now I'll turn this over to our stellar presenters. Welcome.
Good evening, everyone. Thank you so much, Julie, for that wonderful, wonderful introduction. I was listening to you read it. I was like, wow, she sounds really good, whoever she's talking about. So thank you so much. We are excited to be here this evening. I'm going to let Dr. Mcclellan take it from here, and then I'll jump in.
Okay, yes, and thank you. Thank you everyone for being here. We're so excited to share this information with you. We wish we could be there in person to kind of mix it up with you. But this is great. This is great to kind of just share this very important topic with you this evening. So as we've already mentioned, Dr. Ebony White and I are here to speak with you this evening about race and trauma with the focus on urban adolescent identity development. And you've already had a chance to meet us and also take a look at this statement of objectivity that we note that there's no conflict of interest. Your learning objectives for the evening will include describing and relating experiences of racism, both systemic and individualized, as events of trauma. Utilize knowledge of racial trauma and adverse child events to formulate an interdisciplinary plan, build protective factors, and engage communities in trauma-informed care. Further explain adolescent identity development in the theories of the ecological systems and positive youth development. Examine the impact of professional and personal identities on community engagement. And finally, implement culturally centered relationships, building interventions within an interdisciplinary team. That wonderful reading of both Dr. White and I, and just where we're coming from, our positionality, which we'll speak a little more to in the following slides. But as you can see, we are an interdisciplinary team. So we hope to share that with you in the next few minutes together.
And so I'm going to start off by naming a theory that has been quite controversial, that actually has been taught for decades, but has been quite controversial recently. And that's critical race theory, right? And so there are some agreements that we have to make as we're all here together this evening for this presentation to make sense for you, right? And so there are some things we have to agree on. We have to agree on the fact that race exists, even though it is socially constructed. And we also have to agree that our interactions are racialized, right? And so that race plays a role in how we interact with others, and it permeates every area of society. And it's also important to note that race and trauma, particularly in our country, in our context, are inextricably tied together. And so critical race theory, which we're not actually going to talk about tonight, is this radical belief that we teach history and that we speak the truth as in the way that it occurred. And so that we teach history in the way that it occurred and that we speak the truth as it is happening, particularly in regards to race and our racialized interactions. And so as I already stated, these racial inequities, they persist in every area of society. And so when we think about race, oftentimes we use that big or blanketed term people think about individualized experiences, right? And they do have an impact. But when we're talking about, or when I'm talking about race this evening, I really want you to zoom out and think systemically. I want you to think about the educational system. I want you to think about the healthcare system, particularly your own professions, right? I know we have some social workers here, maybe some nurses, hopefully some counselors as well, but I know we have specifically social workers here. So thinking about your profession, your clientele, the folks that you want to work with and the communities that you want to work within, it's important to note the role that race plays in their lived experiences and that race plays in the society around them. It's also important for us to note that because these racial inequities persist, they often result in psychological stress. So they have an actual internal, external impact that can be seen, that can be diagnosed, that can be treated. And so what is racial trauma? So this is, a definition that I, kind of contextualized from the literature, but it's really the cumulative impact of race-based experiences and race-related stress on how people function, or how folks of color function in our society. So it's not just, it's not trauma in a way, and I'll talk about this later, it's not trauma in a way that you have this one incident or this one event that occurred and now I'm having a reaction to what occurred or trying to cope with and trying to deal with the aftermath or the after effect of that occurrence. Racial trauma is cumulative. And so not only have things happened in the past, but they continue to happen and they are going to continue to happen. And so what is that impact on a person's emotions, on their thoughts, on their behaviors, on their relationships? And so I already stated that these inequities result in psychological stress, but it's important to note that psychological stress can lead to trauma responses. And so even if there is no immediate threat to a person's life, those trauma responses still occur. And like I said, I'll define and talk about trauma a little bit later, but I'll give you an example. When we think about all of the, the violence with the deaths of George Floyd and Breonna Taylor and Ahmaud Arbery and Philando Castile and Sandra Bland, all of those things occurring, even for people who didn't live in those communities, who weren't in Minnesota, who weren't in Georgia, who weren't in Kentucky, people who were just watching these things play out on their TV screens, even though they weren't there, they very well could have had a trauma response from witnessing them right through the media. Because when they're looking at the people who are dying or when they're watching these events, it doesn't feel vicarious. It feels personal because the person experiencing it looks like them. And so although that person may be home in their living room watching this event play out, they can still have a trauma response to the event. And so there are many studies, it's all seeped in, all of this is evidence-based, it's all seeped in the literature that this trauma response occurs. And so there are many studies done in like Chicago or all these under-resourced communities that were plagued by violence that talk to, I might speak to that a little bit later, but that speak to how many people living in these communities, in these urban communities, particularly those who belong to racially marginalized groups, they exhibit these symptoms of post-traumatic stress disorder. However, and this is something that I hope that all the participants are listening to, however, they often don't get diagnosed with post-traumatic stress disorder because they don't meet the markers. PTSD typically refers to an incident, no matter how long it occurred, that happened in the past, whereas the trauma that these communities are experiencing is ongoing. And so oftentimes there's a lot of misdiagnosis going on. For example, ADHD, which is attention deficit hyperactivity disorder, is overdiagnosed in children of color, specifically Black children, even though it presents a lot like trauma. Right? And so these children aren't being looked at for what traumas have they experienced or are they having a trauma response? They're being labeled. And so when we go back to the top of this slide, looking at those racial inequities, they're not just being labeled with ADHD, right, or diagnosed with that, they're being labeled as bad, as problematic, as, a disciplinary problem, as disruptive, right? And that's all veiled under racial encoded language. So that's important to note. And so going back to people in these communities exhibiting symptoms of PTSD, we're looking at symptoms such as hypervigilance, which is that constant assessment of safety, right? Constantly looking over your shoulder, feeling like maybe someone's out to get you. And it's not someone being paranoid, right? This is a very valid hypervigilance. This is a very valid suspicion, given the history of people of color, people in urban communities in our society. So we're seeing symptoms of anxiety, we're seeing symptoms of depression. And it's important to note that depression can manifest differently within different groups of people, right? And so something that isn't talked about often as a symptom of depression is anger or anger outbursts. And so going back to misdiagnosing folks, oftentimes if someone, particularly we're thinking about a Black male, is exhibiting what we name as aggressive behavior, they may get diagnosis as antisocial personality disorder or conduct disorder, or just violent or intermittent explosive disorder, but they're not screened for depression, even though anger oftentimes, particularly within these communities, is a sign or a symptom of depression. Substance misuse. I know that my colleague, Dr. Mike Garziak, who's at Westchester, he does a lot of research around substance use, but that is a way that people have used to cope with a lot of the racial trauma that they have been experiencing. And not only are there mental and behavioral psychological symptoms that come along with experiencing these traumas, there's also medical health issues that come along with experiencing these traumas as well, such as high blood pressure. And I'm going to talk about that a little bit later as well. High blood pressure, migraines, poor physical health outcomes. And I believe Dr. Mcclellan is going to speak to this later as well. And hopefully, Dr. Mcclellan, if you think I'm going too fast, I don't have the liberty of interacting with the participants, just let me know to slow down, because I get really passionate about the topic. And so I'm going to read this last bullet point to you all because it's from the CDC this year. And it says, centuries of racism in this country has had a profound and negative impact on communities of color. The impact is pervasive and deeply, I'm sorry, the chat keeps popping up, and deeply embedded in our society, affecting where one lives, learns, works, worships, and plays, and creating inequities in access to a range of social and economic benefits, such as housing, education, wealth, and employment. These conditions, often referred to as social determinants of health, are key drivers of health inequities within communities of color, placing those within these populations at greater risk for poor health outcome. Now, why is this amazing that the CDC put out this statement? It's amazing because for a long time, communities of color, urban communities, marginalized communities have been blamed for their health outcomes, right? So it's been seen as, poor diet, or they're not going to their appointments, they're not listening to the doctor, they're not eating healthy. Whereas this statement really lets us know that it is a systemic problem that has resulted in these poor health outcomes for these communities, right? So we can't talk about obesity within the Black community without talking about food deserts within urban communities, right? And so it's important to note that those things are very connected. They are tied together, right? We can't talk about diet without talking about how much produce costs in contrast to how much, unhealthier foods cost as well, or even clean water when I think about places like Flint, Michigan, and other places. So it's really important as providers that even though we may be working with an individual, couple, family, group, that we have to make sure we're putting their issues within context. And one of those things that we need to look at is race, trauma, race and trauma. All right, so I'm ready for the next slide. Awesome. And so I set out what defined trauma for you, and here we go. And I also want to, I have another colleague that I do trauma work with, and her name is Saloon Wallow Roberts. And a lot of this stuff we talk about and she's brought to me as well. So I wanted to give credit where credit was due. So trauma is the reaction that occurs. And I'll stop there. Oftentimes people think trauma is the incident when it's really the reaction, right? So what may be trauma to one person may not be experienced as trauma to another person. Right. And so some people may say, there are certain events that are just objectively traumatic. And so I argue that that's not the case, that trauma is about the response. So it's the reaction that occurs when the demands of very stressful events exceed our available coping resources and result in severe distress. All right. And so I'll give you an example from the work that I do within the community. I wrote a book chapter one time just around how young folks of color, when they experience trauma, they have something called fragmented brain, right? And so that impacts their ability to focus. And not only that, going back to hypervigilance in urban communities and in communities of color, if they are having a disciplinary interaction with a teacher or with a principal, sometimes their fight or flight response is initiated. And so even though the teacher is saying, sit down or put your pencil down, that's not seen as traumatic. Because of the trauma they've experienced, they're experiencing it as traumatic. So they are elevated, right? And so that's what's important. So something that can seem harmless might be seen as traumatic, depending on the client, the child that you're working with. So also experiencing a serious injury to yourself, witnessing injury, facing imminent threats. And that's really important. So again, going back to what Dr. Janet Helm said, even if it doesn't seem like an imminent threat, or even if we would perceive it as someone wasn't truly in danger, if they feel that way, that's important to contextualize as trauma. Experiencing a violation of personal physical integrity, an emotional wound or shock, often having long-lasting impact. And arrest momentum, I don't know if people are familiar with the book, My Grandmother's Hands. And so I encourage you to read that. It's about trauma. And so if that's something that you continue to be interested in, I encourage you to read that. But he says trauma is also a wordless story our body tells itself about what is safe and what is a threat. And so I really encourage you all to think about that. It's a wordless story. We know that trauma is stored in the body. And sometimes we may not have words to express, or we may go through this questioning of, did that just happen? Am I safe? Going on in our minds that we don't know how to advocate for our safety, or we don't know how to say what's going on with us. That is stored in the body. And the body, as I'm going to talk about another piece of trauma in a second, but in the body lets us know, whether through physical or physiological sensations, cognitions, emotions, right? It lets us know what is safe and what is a threat, particularly given prior experience. Right. And so impact. So multiple forms of violence impact under-resourced urban communities at a disparate rate. And so when I'm talking about multiple forms of violence, I'm thinking about all the layers of development, and I'll talk about ecological systems theory soon. But when we're talking about the home, the community, school, policing, healthcare violence, right? And so there are multiple forms of violence that impact under-resourced communities. And to me, one of the most egregious acts of violence is that they're under-resourced, right? When we think about what's happening in public schools and urban communities, how many students there are to a teacher, right? How much access there are to textbooks and just resources, notebooks, things of that nature. Who is able to get food, right? If you make $2 over, the cutoff line, now you're not able to get free lunch. There are a lot of forms of violence that are occurring, or even the fact that there are metal detectors in police in schools as well, and how that plays into, or what message that sends to students who are attending schools. And I already spoke about this, but I will reiterate it. But symptoms of post-traumatic stress disorder exist at high rates within urban communities. So I already spoke to the hypervigilance. I talked about anger outbursts, substance use, but also isolation, nightmares, and avoidance. And so these things are, when people were coming home from war, from Vietnam, from Korean War, and things of that nature, these are the symptoms that they were seeing for people who were fighting in wars. And what we're saying is in urban communities, particularly those that are plagued by violence, particularly those that are majority minoritized populations, they're exhibiting the same symptoms. And so because this is happening, there's high levels of vulnerability, particularly with children and adolescents being the most vulnerable populations, because they're in that space where their voice is often silenced. They're not seen as knowing what's best for them, right? And so oftentimes when they are speaking, when they have complaints, or when they're trying to advocate for themselves, they tend to be dismissed. And I didn't put this on the slide, but I should have. The majority of young people who complete suicide have told someone that they wanted to do it before it happens. It is interesting because I typically, when I give that statistic, is in the context of another presentation, and I'm doing like a game. And most people in the room say that most young people who complete suicide didn't tell anyone that they wanted to, whereas it's the complete opposite. They do. But what's going on for us that we're not hearing them, we're not believing them, we're not supporting them, right? What's happening within these communities? Or are there just not enough resources? How are we missing this? How are we missing this in these communities? Excuse me. Next slide. Right, and so, and this is really the piece that I wanted to speak to. So we know that trauma has, has an impact on the sympathetic and the parasympathetic nervous system. And so I'm sure that people have heard of fight or flight. Some of us have heard of freeze. Less of us have heard of fold, right? So the fight, flight, freeze, or fold. And so fight is when you just go into, I need survival mode. Flight is when you leave. They're all about survival mode, but flight is when you like flee the scene. Freeze is when you kind of play possum. That's what I liken it to, is like you just freeze up, you feel immobile, which is one of the most more scary responses. And then you have fold, which people don't like to talk about, but we need to speak about more. And that's people who have, for survival, intellectualize the trauma in the moment for survival reasons. And so they say, okay, I estimate that this person is bigger than me, so I should just give in and I have a better chance to get out of this. Right? And so that's also a part of that sympathetic nervous system response as well. And so polyvagal theory, and that goes back to hypervigilance. If you remember, I said at the top of the, or a couple of slides back, about how hypervigilance is that, that heightened sensation of suspicion, or that armor, that guardedness that people have experienced trauma have on, because they're always looking over their shoulder, or they're assessing situations to see if they are safe or unsafe. That's polyvagal theory that we have in our autonomic nervous system. There's a social engagement piece that is basically scouting out the space, our various environments, and letting us know who's safe, who's not safe, what's not safe. And for people who have been traumatized, this is activated constantly, sometimes once a day, sometimes many times throughout the day, depending on the environment. And so going back to it, I'm sure, our nurse, Dr. Mcclellan, can speak to this, but what does it do to a person? What does it do to our systems? What does it do to our psyches? What does it do to our blood pressure to constantly be on guard, I'm on guard, okay, I'm safe. I'm on guard, okay, I'm safe, right? That feeling, how is that impacting not just our emotional and psychological well-being, but how does that impact our relationships? How does it impact how our peers and colleagues see us? How does it impact us when we're going for a job interview, right? So how does that impact all of those spaces? And then more importantly, what is the impact on my health, right? And what does that mean for providers who are working with people who are constantly having to gauge and having to determine whether this is safe for me, even if it's the therapy room, even if it's, you know, the hospital room. What does that mean about what I share? What does that mean about how I connect or struggle to connect? Okay. And so individuals who continue to perceive danger, in their environments, they have this constant autonomic response of alertness that goes from vigilance to terror. And that's really, really important to note because, you know, going back to, you know, our past year in the heightened or the re-energizing of the Black Lives Matter movement, I think about how many people have said and continue to say, you know, just comply, just comply. But if any of us, all participants here, you know, if we think about the last time we were terrified, you know, how do you respond when you're terrified? What is a normal response? What is a valid response when you're terrified, right? So that's important to think about. Okay, next slide. Oh, thank you. I think this is still me. So I'm talking a lot. So it is not the objective severity of the trauma, as I said before, but it's the response. So how was it experienced, not just by the person, but by the community? And I know we're going to cover this and talk about this later, but when you are working with collectivistic communities, so people who value community over individual, it's important to note that it is a shared response. Right, that it is not an individual experience, it is a community experience. And so, you know, doing a little foreshadowing here, what does that mean for your treatment planning? Right? When you know that these experiences, they're not individual, they are community, they are family experiences, regardless if it's one person in the room or not. And so you have to also view it through a cultural lens. It is a cultural experience because context absolutely matters. So if you are the counselor, if you are the social worker, if you are the nurse, you know, how you may be viewing that experience may be very differently than how the individual or the community has perceived it. So always thinking through a cultural lens is really important. And particularly it's important because the way that the community, the way that the individual interprets it, that determines how they're going to cope, or that determines their options for coping, right? Not our perceptions of it. So how they view it, how they perceive it determines their options for action and their options for coping. And that means that cultural differences also exist in regards to what do they do and how they resolve, right? And so oftentimes, not oftentimes, but you know, historically, our professions have been very oppressive, right? And so there's been this amplifying or this elevating of Western modes of help, or Western modes of resources, or Western modes of options and strategies to cope and survive that may not be useful and that may not even be natural or true to the community in which you're working with. And so it's important to make sure that you are valuing communities' beliefs, that you are valuing their ways of coping, and that you're supporting those types of resources as well. And here are, I love these two quotes. I'm going to read them to you, and then we're going to segue to Dr. Mcclellan. But I just thought that, you know, they were amazing. And so the first one says, historical trauma has been described as a complex and collective trauma experienced over time and across generations by a group of people who share an identity, affiliation, or circumstance. It is a cumulative, emotional, and psychological wounding over the lifespan and across generations, emanating from massive group trauma experiences. And then the next one says trauma, and I love this one as a provider, but trauma is not what happens to us, but what we hold inside in the absence of an empathetic witness. And so asking ourselves, you know, is that our role for our clients?
Okay, thank you, Dr. White. So I'm gonna try to expand a bit. I don't know how I could possibly do that, but I'm gonna try to kind of work with the wonderful information that Dr. White just gave and elaborated on, and talk a little bit about where I could position myself as a nurse practitioner, as part of this interdisciplinary team when we look at trauma and the communities. Absolutely, as Dr. White said, the communities that experience this perception and reality and kind of the idea of really how they experience trauma. First and foremost, let's discuss racism as an adverse childhood event, right? Now I know I'm preaching to the choir here. You know, we're all providers who come to this discussion with this idea that absolutely racism is trauma, and it's systemic trauma, it's pervasive trauma, as Dr. White had already mentioned. But when you look at the literature, some of the contemporary literature is starting to discuss in a scholarly way that racism is trauma. But when you look back at the history of ACEs, was not there. And depending on where you look now, even now, you might not always find it. You know, you look at the CDC and you look at all of the plethora of information they have about systemic racism and trauma. But when you look to what they have posted, even right now, even this evening, I checked, they have lots of scholarly articles that cite that racism should be considered an adverse childhood event. But when you look at their full list of risk factors, it's still not there, you know? So I think we have to, you know, be happy that we've made some strides, but we have to realize that we've still got some time to go and some work to do. So just as Dr. White kind of centered us with this discussion, I'm going to center us here that yes, racism is, of course, trauma. Racism should be seen as an adverse childhood event. And just as the National Commission to Address Racism in Nursing, which when I position myself as a nurse here in a couple slides, to talk about the fact that my profession itself is not always doing a wonderful job. But if we define by this National Commission, which was really a commission that included all of the major nursing organizations, including the American Nurses Association and the Academy of Public Health, or Association of Public Health, excuse me, is racism is an assault on the human spirit in the form of biases, prejudices, and the ideology of superiority that persistently cause moral suffering and perpetuate injustice and inequities. So as you can see, we need to just find a way to tip the scales. And I hope in these next couple of slides, we can do that together. So yes, here are the risk factors that ACE in an evidence-based way tries to survey in individuals, in communities. Of course, things like poverty, food insecurity, violence, add racism to that, but then also some of these protective factors that we're going to discuss, such as a supportive adult in the home or in the community, things like housing security. And I'd like to also make sure that in this discussion together, we speak about the realization of justice, or at least the movement towards justice versus just resilience. You know, we need to build resilience. Absolutely, we need to do that. But I'd like to, and Dr. White and I have this conversation quite often, is I would like to think of building resilience as a placeholder for when justice can finally come. Okay. So just positioning this idea of nursing, and why is there a nurse here speaking to you about this? Why could nurses be part of this interdisciplinary team? One, as Dr. White has already mentioned, is we know if we position race as a trauma, as an adverse childhood event, we can also position that physiologic response, right? So just when we talk about the fight or flight, or I love the fold. I have to admit that was the first time I heard that one, right? So the whole idea of the fight or flight, and how I often position this to my population health nursing students, is they really understand the physiologic response, right? We understand that when our bodies that physiologically are made to protect us from harm. That whole analogy of you have the bear and you need to be able to run from the bear. You need to protect yourself, right? So all of a sudden, we have this cortisol release. We know that our heart rate increases so that we can run. Our respiratory rate increases. Our lung capacity, our lungs actually allow for over-oxygenation so that we can run and we can move and we can protect ourselves. What's supposed to happen next once we outrun the bear is physiologically, we should have a recovery period. So all of a sudden our heart rate should decline. Our respiratory rate should normalize. Our cortisol level should also normalize. We should be able to go back to other physiologic processes, some that are cognitive, some that are digestive, being able to eat, be able to nourish ourselves, be able to reproduce if that's our choice. All of these things should happen physiologically when we're able to recover. When we look at the effects of trauma, and I think to Dr. White's point, this ongoing trauma, the trauma that is persistent, that happens once a day, multiple times a day, what we don't get is we never get away from the bear. So physiologically, our heart rates are constantly increased. What does that manifest in a clinical setting? That's hypertension, right? Ongoingly, that would be heart disease. That would be atherosclerosis. That would be a risk of stroke and death from cardiovascular disease. It also could be metabolic changes. And this is why we have an increased risk of diabetes and other metabolic disorders. We have an increase of infertility issues. We also have an increase in cancer, because when we're talking about a chronic manifestation of an inflammatory process, because we're always running from this bear that does not go away, this systemic racism that insults us every day, right, is that we can continue with this systemic constant inflammatory process, which then could cause mutations in our DNA and cause an increased risk of cancer, right? So again, I know I'm preaching to the choir, but my medical students and my nursing students are often not surprised that there could be emotional detriment to trauma, but they're often very surprised when they look at the ACE study that showed a reduced life expectancy in folks that experience trauma, and that now that we're including systemic racism in that, I'm glad that we're having this discussion. And I'm glad I'm able to have this discussion with clinical providers as well. So looking specifically at not just nursing, but let's just say, those of us who spend quite a bit of time in the clinical physiologic space, we want to look at these risk factors and protective factors. The other important thing is to position us in this public health, and this diagram kind of shows what public health really looks at as far as all of our domains of assessment, planning, intervention, and how we really work within those processes. Very important here, and then what's shown on this wheel here is that we have a role in assurance and advocacy. So there are three main concepts in public health. Assurance is one of them. Assessment is the other, assurance and policy development. And it's important for us to all remember that assurance and advocacy later, will really assist us in making sure that we have the community needs developed, assessed, but more importantly, assessed in their own words, in their own voices. We think about the community as having a story, right? Having their voices being heard. And our role in nursing and public health is to make sure that we, in a culturally sensitive and practice cultural humility, to understand in the community's voices what trauma looks like to them and how we can move past building resilience and really advocate for true social change. Okay. I won't keep going, I'll move on to that, to our next slide, but I wanted to make sure that the positionality of nursing and also many of my clinical colleagues really needs to reflect this if we're truly practicing population health. Okay. So what is trauma-informed care, right? So there's lots of definitions that kind of are floating out there when I did this scholarly review, but most really in some way or form or fashion agree that it's an approach to care that assumes an individual or a community is more likely than not to have a history of trauma. And if you look at these guiding principles, depending on which review you look at, there could be 5, there could be 6, but both the CDC and also the Center for Health Care Strategy and SAMHSA agree upon these guiding principles of safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and also cultural and historic and gender issues. So I'd like to also expand into these, what I think might be a relatively new idea, is these 6 considerations for health systems to enhance their informed trauma-informed care and promote racial justice. And both Dr. White and I have the privilege of knowing our friend, Dr. Roberta White, who happens to be not only our Associate Dean of Community Integration, but also the leader of our 11th Street, an administrator of our 11th Street Clinic in North Philadelphia. And both the 11th Street Corridor Clinic and also Bread for the City in Washington, D.C. were 2 entities that worked through funding of the Robert Wood Johnson funding to also work through these 6 considerations of health systems. So I'm just going to go through these 6 steps and just expand a bit. This is not my work, so I also want to give credit where credit is due. This is something that both these health centers, along with Robert Wood Johnson, put together really to give you a plan to allow health systems to have success in building in and promoting racial justice. So the first of these 6 considerations are to involve leadership from the beginning. Okay. I think we've all probably been in situations where we might have been trying to work through a process, but leadership really needs to be involved, not only involved so that you can get some key stakeholders to kind of potentiate what you want to work through, but also leaders of organizations that historically have not been in the practice of racial equity probably need to own that, right? So the idea is for not only these leaderships, but leadership in these organizations to own what portions of racial equality or inequity that they've been involved in. And then building that second is to build an organizational knowledge of racism and trauma. And part of that could be that second step to 1, which is you really want to recognize your past and present harm that could have been included, whether it was intentional or unintentional. Understand the community that you're working in and the picture of that historic systemic racism that is evident in that particular community, because we know all communities experience systemic racism in a different way. And then the third is to define what racial equity or equality focus in trauma-informed care really looks like. So both organizations had different ways to work through that. 11th Street and Dr. Roberta White happens to be working through surveys where they're looking at not only their staff, but also the community around the staff. What actually does racial equity or in trauma-informed care in our community, what should it look like and what should it include? The fourth of the 6 is to establish accountability metrics, which is not an easy thing to do. right? So you need to have a starting point, and it could be that you are considering to look at a cultural assessment, a self-assessment within the group, not only with the staff, certainly staff who are persons of color or identify as persons of color, but also the community around. So I know at 11th Street, they are working through an anti-racism survey. And I believe, Ebony, you might be part of this, I know I am too, is the hiring process of what is happening. Because historically, the hiring process was something that the members of that community did not feel always reflected racial equity. And then 5 is to elevate the patient and the community's voices to disrupt existing power structures. So we know that often communities in their own voice will say that racism is primarily an issue of power, right? So to be able to rise up those voices and to be able to disrupt the current power structure, to ally with community members. So I hope to speak to this a bit when I position myself as a Caucasian woman, to use my privilege to help to work through any barriers that might be there. And certainly to not re-traumatize anyone. And then 6th is to support staff of color, have the lived experiences, just as the community surrounding your organization, your care facility, that community certainly has lived experiences, but staff members do as well. So I think we've always known that trauma-informed care should include the full collective of staff members, providers, and also patients or community that is being served, but to specifically support staff members of color and let them rise up with their voices of lived experiences. And also in this initiative, it's noted that often there could be reported moral conflict or moral difficulty in members of the staff that are identified as persons of color and being involved in initiatives that they feel are not elevating the work that they want to do to really be able to be part of increasing racial equity. So that is going to cause a moral dilemma or a moral issue as well. Okay, so Dr. White, I think you're next.
You can show the full slide. And so, you know, a big part of this presentation is talking about urban adolescent identity development. And so the model that I often use, or one of the models that I often use, is ecological systems theory. And it was developed by Uri Bronfenbrenner, who was a child developmental psychologist. And he looked at development along these spheres, or this hierarchy, I'll say. But I like that he puts it around it, because that's really what it is like. And so it's important to note that there's a microsystem, a meso system, an exosystem, a macro system, and then the chrono system. And so if we are the individual, we're situating ourselves in that green. I don't know if you can, how well you can see this graphic, but if we situate ourselves right in the middle where it says individual, ecological systems theory says, let's think about the things that influence our development, our maturation, right? How we move, how we process, how we perceive ourselves, how we perceive our capabilities, as well as what opportunities we see we see for ourselves. And so there are things absolutely innately that we have as individuals, but that microsystem that's surrounding the individual, which is things like family, friends, siblings, teachers, those things influence our development. And how do we look at the microsystem? The microsystem are those spaces and places where your presence impacts that space, right? So you're not just a recipient, you're a participant, you're contributing to the environment, right? And so when I'm home, or when I'm at my parents' house and my sister and her daughters are there and my dog is there, it feels very differently if I leave or remove my dog from the situation, or remove my sister and my nieces from the situation, right? It changes the dynamic. So those are the things that are at the microsystem level. Now, the Meso System is the relationship between microsystems. And so the interaction that one system has on the other. And so when I think about my own upbringing, and I was raised in a missionary Baptist church, and there were messages that I received at church that competed with messages that I received at school. And there are messages that I received at school that maybe gelled well with messages I received at church, right? And then how did those messages from both of those places gel with the messages that I was receiving from home, right? So what is the clash? What is the complement of those systems? Essentially, what is the relationship of those systems between each other? And what impact then does that have on my development as a child, or as I'm developing as an individual? And then you have the exosystem. And so that's an interaction with a non-direct system. And so the example I always use when I talk about this system is being raised by an unpartnered parent until I was 14 years old. And so my mother, she worked a lot. She worked outside of the home, and my grandmother played a really important role in the upbringing of my sister and I. And so my mother's healthcare directly impacted me, even though it was, her healthcare from her job. My mother's, the hours that she had to work directly impacted me because it let me know how much access I had to her, how much FaceTime I would get to her, even down to the amount of sick and vacation time that she got directly impacted me, because who's going to show up at my doctor's appointments? How many times? How does that affect when she decides to take off or not? How does that affect if she's able to come support me at my sporting and activity events, right? Her income, the pay that she got from that job. So even though I may have never stepped foot in her workplace had a direct impact on my development. And so those are the things at the exosystem. Although I may not, be there, those systems are very close to me still. And then you have the macro system. And the macro system, is that light blue around all of the systems. And at that level are things like social conditions, are things like culture, policies, laws, right? These are the written and unwritten rules of society. And so racism would be at that level. Okay, that's on the macro system level. And the level that's missing from this graphic is the Chrono System. And so that's just the passage of time. And so it was very different for my grandmother who grew up in the 30s and 40s versus, very different for my grandmother who grew up in the 30s and 40s as a Black woman than it is for me growing up in in the 70s or in the 80s and 90s as a Black woman, right? And so that passage of time, what did it look like? How did it look differently in the 80s and 90s from how it looked in the 30s and 40s, or even the 50s and 60s, or even in today's time, right? The song WAP would never have played on the radio in my grandmother's time, right? And so, putting that into some context. Now, the really important piece about this system is that the systems above impact all of the systems below. And so what does that mean? If we're looking at the macro system, and so say something like policies, right? So policies impact my parents' work, right? So policies that are written at the governmental level impact my parents' work, right? They also impact what the curriculum is in my school that I'm learning, those policies that are written, right? And they also then impact how I see myself, what I see for options. If we think about the fight going on, in Texas and other places around, pro-choice options, right? And so these laws are put into place. What does that mean for my development as a woman? What does that mean that, these white men get to make decisions about my body? So those things, even though they're at the macro system level, they have an impact on an individual's development. And so we're thinking about adolescents in the urban system. They're constantly receiving messages, and I'll talk about that too. They're constantly receiving messages, not just about society as a whole, but they're receiving messages about who they are, how their families are seen, how they are seen, how their communities are seeing. And they're receiving those messages, not just within the home, not just within their schools and their communities, but they're receiving them in the media. They're receiving them in laws and policies. They're receiving them when they're watching what happens, on January 6th at the Capitol. They're receiving these messages about who they are and what their options are for action, right? What their options are for choosing behaviors, right? What their yeses mean, what their nos mean. So it's really important for us to think about when we're working with our clients. Next slide. And so I said I would talk about this, right? And so stereotypes have often been the basis of expectations for urban adolescents, right? So when we look at children functioning in the classroom, one child may be seen as curious, while another is seen as disruptive. And it's not because they're exhibiting different behaviors. It's because of how stereotypes and how our biases and how all those things at the big system have infiltrated those lower systems are playing out even within our classrooms. And so if they're playing out in our classrooms, that means that they're playing out in our counseling rooms as well, right? How are two people, I'll say, two clients, two patients receiving different diagnoses, but they're exhibiting similar behaviors? What are we looking at, right? Or what are we not seeing? And how our own identities, our own biases, and Dr. Kim and I are going to talk about, like she said, we'll position ourselves a little bit more later, but that plays a role in the care that we give and how we perceive symptoms and how we perceive even crises and how we perceive very natural responses. One of my favorite psychologists is Dr. Thomas Parham, and he often says that an abnormal response to an abnormal situation is a normal response, right? And oftentimes we are so focused on responses that we're not looking at antecedents. We're not looking at the context that the behavior is occurring in. And so we must, Okeke and colleagues said that we must reconcile how race and the meaning ascribed to race by the larger society intersects with personal identity. And so it's not enough for us to say to someone who says, I'm not going to live past 21, which some of my teens that I see in my practice have said to me. Like, I say, where do you see yourself in 20 years? They say, well, I don't see myself in 20 years. And I hear a common response to that is, why would you think that? You could be anything you want to be, all of those things. But that's coming from a place that's not steeped in their context. We have to examine what's going on around them that they're not seeing life beyond this age. And how do we work with them where they are in that? Instead of, from our own lens, thinking that we're instilling hope, saying, no, you can do whatever you can be whatever you want to be. We have to validate their perspective. We have to validate their context. And we have to say, you know what, there's a reason, when we look at their own personal identities, that they're not seeing these options for actions, that their pathways seem very narrow. And so we have to interact, and Dr. Kim spoke to this earlier, we have to interact or intervene at the individual level, absolutely. But central to our identity as healthcare providers is an advocacy identity as well. How are we advocating on a systemic level for our clients, for our patients? And I always like to talk about stereotype threat just to make it real and bring my point home. But there was a study done in 2009 where students performed 2 standard deviations lower or better, depending on the race of their proctor. And these are students of color. So we know that young people are aware of race and phenotype and all of those things at a very early age, even upon entering kindergarten. By middle school, they're very aware of the stereotypes associated with them and even before. But these middle school students, which doesn't speak to their capacity, right, or their intelligence, the same students can take the same test and get an A on it with one teacher, take that same test and get a C on it with another. Going back to polyvagal theory, they're assessing what's safe. and they're responding based off of that, right? And so if I feel, you know, hyper aroused, I feel like I'm not safe, and I don't even know that my system is agitated, what does that mean for my focus? If I feel like my teacher doesn't see me, if I feel like my therapist doesn't see me, what does that mean for, you know, the things that I share? Absolutely. So we can, I know I've done a lot of effects, but we can go to the next slide. Yeah, you can do the full slide because I already started speaking about it. Yep. And so, like I said, 80% of students are aware of social stereotypes and impact self-esteem and performance. And like I said earlier, students of color in that study performed differently solely based on the proctor, which to me was so saddening, right? Heart-wrenching, but also so enlightening at the same time, because we know how, you know, racist the bell curve was. And we know that IQ tests and SATs, HSPTs, that all these tests that test intelligence have racial bias, right? But we still use them. And we use them and we make declarations like, these students aren't as smart as these students. And so these stereotypes continue to persist, they continue to permeate, and they are a form of violence against these communities. And that impacts then, if I'm being told that I'm not smart, if our students, if our adolescents are being told that you're not smart, these are your only options, how then are they going to interact in the world? What opportunities are they going to see as opportunities for them? And then more importantly, for the social workers and counselors and providers here, you know, what does that mean for you as a clinician? What does that mean for you as a provider, and how you are supporting this population? And so I love positive youth development. And this was developed by, let me see, Zaret Foster. I don't think I put the citation on here. And, you know, their colleagues. And there were 5 things that they talked about in working with urban youth to foster positive youth development, excuse me. Excuse me. And so highlighting competence. And competence is not just in one thing, excuse me. Excuse my voice. So competence is not just in one area, right? And so we have to redefine competence. And so we know that urban adolescents are intelligent, but we also know that there are different forms of intelligence, right? And so we want to highlight their competency. Find out what youth are good at. And then you can foster competence so that they can achieve according to what is seen as achievement in their area. And what am I speaking to? So Dr. Kim spoke earlier about our conversations around resilience and how she sees us fostering resilience as a placeholder for justice, right? And what does that mean? It means that this conversation around resilience has been very oppressive. We have celebrated people who can basically take a licking and keep on ticking without really addressing the licking part. Like, why are these communities getting beat down so much? How do we address this? And so the same thing applies here. You know, unfortunately, in our society, we have measurements of success. We have measurements of achievement, and achieving in certain ways opens doors for folks. And so, you know, unfortunately, we have to work within the system while we're working around the system and working outside the system, and then, you know, tearing down the system and rebuilding it as well. But we want to foster competence. And so if I am able to ensure teens, ensure adolescents that they are cared for, and that's one of the 5 as well, then I can say, listen, read this. Let me help you with this. How can I support you with math? Oh my God, you're so smart. That's great what you did. And so you want to foster, they already know things. And I'll give you an example. Students who, or children who grow up in environments where they have to navigate multiple oppressions on a daily basis have so much more life experience than students who don't, right? They have this competence that really can't be taught in a classroom. And it's important to value that, right? And so one of the ways we can do that as clinicians is we want to foster competence. The next thing is to help to increase confidence, right? And so how do you build confidence? You do something, you get better at it, or maybe you do it right, or you get the answers that we want, and then you keep doing it again. And so instead of focusing on what's wrong, saying, oh my God, you did this so well, try it this way, right? Instead of saying, you need to improve, or why, how did you get this wrong? You already learned about this. And I'll give you an example. I had a teen, a boy 12 years old, as a client, and he's someone who was seen as aggressive. So he will often maybe like throw desks, throw things in class, punch the walls or something like that. And so one day he was in class and his teacher irritated him. He used the word pissed me off, right? His teacher pissed him off, and he got up and he walked out of class. And he got suspended for getting up and walking out of class. This is the advocacy piece that I'll speak to later. And so he came to me, you know, we had session, I think like 1 day or 2 days later, and he was just so down, like, you know, I got suspended again. And he's telling me what happened. And when he finished telling me what happened, I said, oh my God, that is so great. And he looked at me like I had two heads. I said, so wait a minute, your teacher said this, which was not right, but you got up and you walked away? And he's like, yeah. And I said, so you didn't throw a desk? You didn't punch it? You didn't throw anything? You didn't curse? That's amazing. And his whole body language changed. And so then when I finished the session, I walked out to the waiting room with his parents. I said, I cannot believe, I'm so impressed that he was able to walk away. That's so amazing, because they could see me praising that behavior as well. And that's building confidence now. That's celebrating his progress. And then connection, there's a statement, and I don't know where it came from. I'll say it's anonymous, but a colleague of mine uses it all the time. She says, you know, people don't care how much you know until they know how much you care. Right? And so connection is so important, particularly with collectivistic communities. And Dr. Kim can speak to this with all of the community work that she does. There has to be a connection. And because you all are social workers or budding social workers, you know that what determines people's success in therapy, more than theoretical approach, more than strategies, right? More than, you know, if something worked that you told them to work, what determines people's success in therapy is connection, is their relationship with their clinician, is that rapport. Same thing with adolescents. You have to connect with them at their level. I can't tell you how many teens came into my office and thought they weren't going to talk to me. But you take interest into what they are interested in. Caring, and that's self-explanatory, and I believe that they permeate all of them, but you have to genuinely be authentic. You know, when you're working with people, it can't be a paycheck. And I say that every time I, you know, do presentations. You know, this is not the field that you go into if you want to make money. This is the field you go into to make a difference, right? To have impact, to connect, to be impacted, right? And so you have to actually care about what you're doing. And then finally, character, right? You want to make sure that people have integrity. And so the theory that I mostly operate from as a clinician is reality therapy, which is really, you know, the big thing is choices, 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 choices. And I tell parents all the time, listen, my goal is not to change your child, nor is it to change their behavior. My goal is to help them increase their awareness and then be okay with the consequences of any decision that they make, right? And so if they make a choice If they're comfortable with the consequences of their choice, that's their choice. They're honest about it, they're open about it, they thought it out and they acted. And they're saying this was worth it. This was worth it. Me walking out of class was worth the suspension. Now, a wonderful thing happens when when a child realizes they're empowered. Magically, their behavior does change. But that's not the goal, right? The goal is the increased awareness to figure out what's going on with me. Why am I choosing these behaviors, right? And sometimes, as I said before, my behaviors are an abnormal response to an abnormal situation, which makes it normal. And so we have to both address the behavior and the situation. And so when working with adolescents in urban environments, you want to remember these 5 things are so significant when you're doing your clinical work. So it can't just be about your diagnosis and the strategies and the theory. It has to be about these 5 things as well. And so how are you connecting? How are you caring? How are you fostering confidence, right? How are you praising character development as well? And remember, these aren't your own definitions, but seeped in the cultural values and the community beliefs of the folks that you're working with. Did you want me to go first?
Sure, go ahead. Yeah, yeah.
And so it's important, in our work to really situate ourselves. And it's important for all the participants here, for you to situate yourselves as well, because who you are influences how you work, influences how you're seen. And so I identify as a Black American African, actually, who is a cisgender woman, Christian, able-bodied, heterosexual, native English speaker, and American citizen. I'm also a professor, therapist, middle to upper middle class, and here's the thing, and I'll start there. I have struggled with openly speaking about my class status because I'm someone who was raised financially, I'm learning that we were poor. So we lived in what we called the projects, the housing projects, and we moved around a lot. And so I have a very strong working class, or I have a very strong identity to that class, whatever that class is. And so even me saying middle or upper middle class, and I know for the reasons, but for many reasons, makes me cringe. Because I know how people who were in my class were seen when I was not in my class, right? And what that meant. And so, I'm working on a book, I think Dr. Kim knows this, and it's called, I talk about being in this in-between space where, as a Black woman professor, I'm often in predominantly white spaces. And so I have access to the spaces that the people from my communities don't have access to. But when I'm in these spaces, even though I have access there, I'm not fully accepted in these spaces. So it's very clear that I stick out in these spaces. But because now I have access to these spaces, when I go back to my community, I stick out there too, because they no longer see me as an insider to the extent that I see myself, right? And so it's this weird position to be in, because I have to acknowledge and recognize that my life does look very differently now from those, from the folks that I work with. At the same time, our stories are connected. And I carry that with me. But I would be remiss if I didn't acknowledge my class status, my able-bodied status, right? My heterosexual status, when I'm working with folks, particularly folks who don't have those statuses, and that impacts the work. And it doesn't mean that they have to just get over it and allow me to help them. What it means that I have to consider that and work harder so that I can connect. I have to own those identities so that I can connect, while still owning, I very much have oppressed identities as well, that I'm navigating throughout the world. And so when I'm working with teams, we have those conversations, right? They say, you don't know what it's like. You're not from where I'm from. And I can say, yeah, I'm from there, but they're like, well, you're not there no more, right? And so really navigating, clearly I love my teams, really navigating those conversations and owning it, saying, you know what, you're right. So what is it like now for you as a team? Some of it I can't relate to. Some of it I can. Let's connect, you know, and using that story. But because of who I am, I know that it impacts how I diagnose, or choosing to diagnose or not to diagnose, right? It impacts what I see as crises. It impacts how I view anger, right? Because I have these experiences and I know they show up in those spaces, no matter how much we want to shelve or scaffold or whatever, those things.
Okay, thank you, Dr. White. I identify as a white, Irish, Scottish, American, cisgendered woman. So my heritage or ancestry is Irish and Scottish, although I don't have family there currently. I also identify as a Christian, but also spiritual, able-bodied, heterosexual woman. I also identify as a third generation nurse, and I wanted to really think about this. I know that I'm a third generation nurse. I know that I'm a third generation educator. But when I specifically think of nursing, I was indoctrinated from a very young age to think of nursing not as many of my students actually do, when they say, I wanted to become a nurse because I wanted to work in a hospital. To me, that was never really what nursing was. So I've always looked at nursing from the community systemic advocacy role, which is, I think, why I just make that really my passion or my mission. And I try to generate that interest in my students as well. I'm also a professor, a nurse practitioner. And I too, Ebony, it's really interesting to hear you share this, because I too struggle with this upper middle class. I am certainly very privileged. I have lots of privilege there. But growing up, one of my privileges was not to be part of that class. I was living in an impoverished home, living in a community that had a lot of food insecurity and a lot of violence around it. So to walk into many of my colleagues, as Dr. White said, to walk into a predominantly white profession in an institution and institutions that are predominantly privileged, and then to almost feel like you're eavesdropping into a community that you're not really part of. I did not grow up there. It's very interesting. It's interesting to almost spy on what's going on, and then come back to a community that I feel a bit more comfortable in, which is usually the workspace that Dr. White and I do together, and many of our colleagues as well. Yeah, and I think that also the other thing I want to make sure in this positioning that I speak a bit about, and I alluded to this when I spoke about trauma and working through privilege to try to assist trauma and to be able to be a provider that really talks about and practices trauma-informed care, is I think with my privilege of being a Caucasian woman, I always want to be very mindful that I am not centering whiteness in a way that could also re-traumatize, right? So this whole idea that we don't want to, whether it's inadvertent or not, look at our privilege as the standard. Dr. White spoke about kind of, mentioning to teens that, well, I might understand because I'm in your neighborhood, but yeah, she's not in that neighborhood anymore. There could be understanding I have, but I want to make sure that I am not using my understanding of my privilege and using that standard as the norm that all else is judged by. It's really, as providers, as counselors, our role is really not to judge, make moral judgment, but to really meet community members where they are, hear their feelings in their voice, and then make sure that we're not practicing things like ethnocentrism, and we're really kind of working through the community voice and then engaging that way. I think now we're going to open questions, right? Which it looks like we have a lot of.
So I just want to thank you for your wonderful presentations, Dr. White and Dr. Mcclellan. And we are going to move into the Q&A portion of tonight's training. So we do have one question so far, and it is in reference to the positive youth interactions, and that is, how can we educate the schools?
Oh, I mean, yes. So I'll tell you what I do in my work. I said earlier that central to, and I have to say this because it's bothering me, it should be AC, I messed up, it should be ACS, Approved Clinical Supervisor, under my name, just in case there are any ACSs here, and I don't want them calling the board on me that I got their credential wrong. So with that said, I said earlier that central to our identity as providers is an advocacy stance, an advocacy identity. And so a few of the things that I've done in my own community, and you can see it not in the bio that was read, I don't think she said it in the bio that was read, but I do trainings within my community with various entities. And so I do trainings with law enforcement, including like the local police department, FBI, even the state. I do trainings with educators. I've written not necessarily curriculum, but strategies for educators that many educators have used in their classrooms for working with students who have experienced trauma as an educator. I also have attended city council meetings and school board meetings to advocate. And then a few years back, I received a grant to do a free kind of counseling group with adolescents in this certain area of Trenton, New Jersey that's highly plagued by violence. And I took a PAR approach, which is participatory action research, but we don't have to go into that tonight. And a part of that project was that they had to do a social justice project at the end. And they ended up recording a PSA that the student themselves showed around to schools, went to school board meetings, things of that nature, and that amplified their own voice, and they own that video. It's theirs to show, it's there to talk about, it's their voices. And so how do we educate the school? We make sure we insert ourselves into our communities. And so regardless of what community that you're working in, you need to be involved in that community. You need to attend the city council meetings, the school board meetings, familiarize yourself with the players. And again, take that caring posture. So a lot of the trainings that I do, I get paid for. A lot of the trainings that I do, I don't get paid for. But my community is so important to me that I'm okay with that, right? And so, of course, if the, like a lot of the law enforcement has paid me, but my initial work with the law enforcement, the local law enforcement and with the FBI, it wasn't paid. However, policing has been a problem in my community. So if I'm allowed entry into this space, I'm going to take it because it's important that our voices are there. And so that's what you do. You insert yourself and you advocate to the best of your ability. Oh, and also there's power in numbers. I'm a member of various organizations. And so at any time, if I, champion an issue, which I often do, as Dr. Mcclellan probably knows, if I champion an issue, I reach out to my networks like, listen, I need you all to sign a letter or to write a letter and send it to this person or call the senator or, all of those things. I galvanize because there's power in numbers. What people don't know is that the most powerful voices are the most marginalized voices. And so the letters that have made the most impact were the letters that actually came from the community and not the professionals, not the educated folks. But when students are writing letters, when their parents are complaining to the Board of Education, right? That's what has a lot of impact. And so you want to make sure that you have good relations with the community, because they get to have a voice and you get to maybe be an entry for them or a tool for them. But it's really them who get to make the impact, and you're an actor in that.
Okay, thank you, Dr. White. And as a piggyback off that first question, another question is, as a teacher, I like to access some of your strategies that I can use in the classroom. Where can I do this?
So it's called the HELP strategy. It was published in, oh God. So this is what I can do, Fatima, or I don't know who I send it to. I can send you a link to where to find it, and maybe you can send that out.
Yes, we can do that. Thank you.
Or, and I know I sent my CV. If you go on my CV, the citation is under publications. So if you want it before then, feel free to, if you all have access to my CV, to just, copy and paste, and then it'll pop up.
Okay, thank you. So this next question is, what recommendations or references would you offer for discussing trauma and the socioeconomic determinants of health with human resource professionals?
Kim, you want to take that one?
I saw that question. I'm trying to think of anything specifically. Yeah, I know we have quite a few listed in our presentation, but what's going to come along, I think, is a whole reference list. So let me think a little more about that. Sorry.
Dr. White, do you have any?
Yeah, I was going to say Dr. McClellan, excuse me, and I, clearly we do trainings, right? And so we're willing to support you, because we did a panel, and we all have resources. We did a panel for St. Chris's and for other folks, and there were HR professionals there as well, and they found it useful. And so we can speak to that as well and bring some of our colleagues on if you're an HR professional from an organization. Yes, there are going to be references to follow that you can look to. Also, you can go to the various websites that speak to it, but I really do think that there's a place for training here, because oftentimes I send out resources for folks or send out things for them to read, but for them to translate it into action, it seems to be some obstacles there. And so I would say, look up some really good people who train on these topics and bring them in for prolonged engagement, so that there can be impact.
Okay, and the next question is, are there any good books on racial trauma other than the ones you mentioned?
Books, articles, movies, right? Documentaries, absolutely. To me, the racial trauma has to be talked about from a human perspective. And so reading about racial trauma as racial trauma is not as effective as reading and watching the stories of racial trauma. And I'll give you an example. So I did tell you about, my grandmother's hands, but also, and I haven't been able to watch it. And I know many of my peers of color haven't been able to watch it, but I think it was a 4-part series called When They See Us, that speaks to racial trauma. One of my favorite movies, The Color Purple, speaks to racial trauma, right? If you look at the movie The Help, but there are even, real life incidents, and I'll give you an example. If you think about what happened to Nicole Hannah Jones, I'm getting her name wrong, or, other folks who went up for tenure and got denied because their work was based in, in African-American issues. So they weren't seen as important or as significant. And so that's racial trauma as well. But yeah, there are many books, there are many articles. Some of the articles that we're going to include in our reference list are going to be there. And then also what I can do, and again, I don't know if I'm going to send it to Fatima or Wendy, I can send a reading list as well. I know Between the World and Me by Ta-Nehisi Coates, he speaks to racial trauma as well. If you look at any of Patricia Hill Collins' work or Dr. Beverly Tatum's work, I mean, these folks, Audre Lorde's work, James Baldwin, right? All these things speak to, all these authors and forebearers really speak to racial trauma as well. But I'll try to compile a small list because it'll go on and on and on.
Thank you. That would be really helpful. And this question is for you, Dr. Mcclellan. So it says, as a nurse, have you witnessed incidents of racial injustices in the hospital setting? If so, what did this look like and how was it addressed?
Oh, that's a great question. Yes, of course, yes. Racial injustice in hospitals, in care facilities, in community health centers, with those who fund and make policies around centers. So I think when I try to struggle to answer what it looks like, I can certainly give you examples, which I don't mind sharing a few examples, but I think that it runs such a wide and broad gamut that it certainly looks different considering, where you're at, what the community is, and how either implicit or overt it really is. I mean, we know that there's implicit or microaggressions that occur constantly. And just being attuned to that and being able to call it out, those of us that are advocates, to call out that behavior to try to make real lasting change. So I'm thinking of an example, and it's been quite a while since I've been in a hospital. I'm mostly out in the community now, but my work in the communities surrounding HIV care, it happens all the time. So someone walks in that, as Dr. White said, mentions stereotypes, that stereotypically is part of either a race, an ethnicity, a religion that unfortunately is affected by HIV in a disparaged proportion or way. And you assume that that person is going to have all the risk factors that we stereotypically think of with HIV, and someone that walks in that maybe does not carry that stereotype, and they're not thought of as at risk for HIV. And the person that looks a certain way is tested and treated in one way with bias, and the person who does not fit that stereotype is not. Unfortunately, both are harmed, because the person who doesn't look like stereotypically they would be at risk is not given all the prevention and the education that they needed. And of course, the one that does, phenotypically present as a risk for HIV is judged. And certainly whether the person doing that means well or not, it doesn't matter. The trauma has occurred. It happens quite often as well with, when I have the privilege of taking care of either a family or a woman who decides that she wants to have a pregnancy with HIV, right? So if she or her partner are HIV positive and they're persons of color, we know that automatically, again, all the issues in this country and globally with disparity with women of color seeking pregnancy, maternal health. What does motherhood really mean globally? We know that there's lots of implicit bias that happens there. One story I can tell, I don't want to take too much time. I want us to get to the other questions, but one story I can tell is that, and this was specifically with a woman, her country of origin was actually in sub-Saharan Africa, and she delivered a very healthy baby. She herself was HIV positive. She was a young adult, so she was about 20 years old. This was her first baby. And when she wanted to take the baby home, and she refused to take, I guess it was a custom at the hospital to not only send babies home with car seats, but also send them home with a stroller. And she did not want the stroller because culturally to her, it was the norm to actually wrap her baby up in this beautiful fabric, felt much more bonded and protected. This was her culture. And I, at that time, was her care provider in the HIV center. And I got a call that the person at the hospital that was discharging her was concerned that she wasn't bonding with her baby, because why would she not take all the things that the hospital wanted to give her to keep her baby safe? When it was really completely the opposite. It was a beautiful story about a mom who culturally her bonding was to keep the baby close in this gorgeous fabric that the women in her family had given her and made her. And that's labeling, which I think if probably she wasn't a person of color, a person that was HIV positive, that probably would not have happened.
Thank you so much for sharing it. So our next question is about hearing discussion for the need to move from trauma-informed to healing-centered practice. And could either of you share your thoughts on this, or are they a separate approach? And is healing-informed considered the next step in this?
Do you want me to take the first stab at that, Dr. White?
Sure, you can. I'm very critical of the whole languaging stuff, so I'll let you go first.
Okay. And I have to, full disclosure here. I've heard both terms. I've not heard healing approach quite as often. Dr. White, you can tell me if I'm getting this right, but wherever I have heard healing approach, it's usually been when a center or a practice is trying to become a bit more mindful. Using the space, a mindful space, a more of a spiritual practice, almost of meditation, to create space between the person experiencing trauma and the trauma itself, to kind of create that healing space, and just trying to, I think, make it more inclusive to the mindful practice. I don't know, how did I do? That's where I've seen it or heard.
Oh, you're amazing.
No.
As always. Yeah, and so yes, and then also, people, there is conversation around, instead of saying trauma informed, say healing informed, which to me, particularly when we talk about, like, it works if you're talking to people who have experienced past trauma, right? Where, let's help them heal, but it doesn't work when you're talking about people who experience persistent trauma, right? Because we can't talk about healing as long as the trauma is still occurring. And as you know, even as a nurse and healthcare provider, you know that if you cut me on my hand, or if I get a cut on my hand, you can heal it, right? But if I continue to cut my hand while you're trying to stitch it up, there's no opportunity for us to be in the healing phase, because I'm continually getting wounded. And so when speaking about trauma-informed care, I think we should still name it trauma-informed care. I think when we try to move the conversation to healing-informed care, then we aren't taking into consideration people whose trauma isn't post.
Okay, thank you both. And as a follow-up to that question, for organizations that are currently working towards becoming trauma-informed and healing-centered, what questions should they be asking themselves in the process to be sure that they are continually anchoring in considerations around race?
I didn't hear the last part. What questions should they ask themselves, you said?
Yes, what questions should they be asking themselves in the process to be sure that they are continually anchoring in considerations around race?
Absolutely. And Fatim, I don't know if this is an answer to that person's question, but I will say recently, you know, I'm in a fight now around the advocacy issue. You know, people are feeling inundated with talk about race. They're feeling like, you know, all this racial stuff is everywhere. And they want to talk about other marginalizations. They want to talk about disabilities. They want to talk about LGBT. They want to talk about religious discrimination. And we should be talking about all of those things. But the problem is people want to talk about those things instead of talking about race, when race permeates all of those other oppressions as well. And so if a place is really wanting to focus on racial equity and even racial healing, then whatever the conversation, race should always be a part of it, right? And so that should just be the top of the list, and being explicit about what you're saying and not just using language that is comfortable for folks, but using language that is direct, that is explicit, and that takes a stance, right? But more importantly, folks in power in positions at these places, it is also important and necessary that they're undergoing a self-reflective, introspective process on a regular basis. What are my biases? What are my identities? How are they showing up in this space? And engaging, and that's one of the strategies, right, that I tell teachers to do. Every day, at the beginning of the day, do a check-in. Where are you today? How are you feeling? And at the end of the day, ask yourself a few questions. You know, what student do I feel connected to? Why is that? What student do I feel less connected to? What's going on there? Right? Doing that, engaging in that reflexive process on a regular basis.
Thank you so much for that. And thank you both again for an amazing presentation for tonight's training.